Hello, everyone. The audio is working. Yes, the audio is working. Who am I talking to? I'm talking to myself. Not talking to anybody. No, I'm talking to you guys. I'm not talking to myself. I'm not crazy. Okay. NSAIDs and other non-opioid analgesics. This is for the MSK is module, which is my abbreviation. I don't know if other people abbreviate it like that, but musculoskeletal. I abbreviate MSK. I don't know if, like I said, if that's a department thing or not. I don't know where I got that from. So this is going to be the first one. And again, you guys can listen to these in any order. It's just the first one I'm recording. But just before we get into it, this module is pretty massive when it comes to pharmacology. The last 2 years I've taught this. The students have not been happy with me because of this module. No, I mean the feedback's been like they wish they had more time with these drugs. These drugs are ubiquitous, meaning you see them everywhere, inpatient, outpatient, old, young, little, big. I don't know what other, everybody and your mama. No, everybody and your neighbors, cousin, everyone's on, or has exposure with this. Something as simple as an over-the-counter Tylenol, which is brand name for acetaminophen, to something more complex like some IV morphine or something. I don't know. So it just really is one of those things that everyone has pain, and a lot of your healthcare interactions are going to be with pain medications. And so, yeah. So my apologies. I didn't, I don't make this extra kind of extra robust on purpose. It's what the kids are saying these days. It is what it is. No, but and I hate that. That annoys me so much. But I know I just said it. When the students would tell me that, I'm like, don't say that, and then I'm saying it now. You guys are rubbing off on me. But yeah, so just a big warning here with this module. I'm hoping to get these lectures up early, even before the GU module is over, and it helped, and hopefully that'll help you guys. But anyways, let's just jump into it. These are non-steroidal anti-inflammatory drugs, is what the abbreviation NSAID is for, and then other non-opioid analgesics. And analgesics is the scientific fancy way of saying pain medication. So we will be talking about pain medication, and they do other things as well. So as always, please note that. So here's a big list here. You might want to put a little star or something here to denote that aspirin is going to be the prototypical, kind of the prototype of the NSAIDs. And the other thing is too that it has some different properties. So not all NSAIDs are created equal. So I usually kind of draw a line here. Definitely for categorization purposes, I mean, they're all NSAIDs, so definitely, testing purposes and stuff, aspirin is an NSAID, right? But it's different, and we're going to see how it's different, and it's unique and it's special, and I like it. No, it's my friend. Aspirin's my friend. No, but it's a little bit different. So yeah, for studying purposes, have them all as NSAIDs, but you can go ahead but definitely keep aspirin separate, and it's its own person. Okay, guys, you got to start respecting aspirin now. But yeah, so we'll get into it. All of the NSAIDs inhibit the eicosanoids from arachidonic acid. So great visual representation here. Definitely want you guys to make sure you're studying this for mechanism of action. You notice here it hits the cyclooxygenase inhibitor. Here's the NSAIDs here. Some other medications here. We've talked about the corticosteroids. You notice that that they're up here and they have an effect as well. And so that's part of why they're called this. They're called non-steroidal in reference to the corticosteroids. So they're not related to them. And so that's part of the reason that they're named that, non-steroidal anti-inflammatory, because you guys will remember, hopefully, that the corticosteroids do have anti-inflammatory properties as well. But you'll notice they're farther up on the tree, or the cascade, I don't know what you want to call this. They're farther up on it, and they knock out more things. And notice they have have some effects over here, where the NSAIDs are just on this branch of the tree, and they are blocking the cyclooxygenase. And then they definitely look at what that means as far as its effects are concerned. And so you notice too that the minus just means inhibit. So these are NSAIDs are blocking, or they're inhibiting the cyclooxygenase, which we are going to abbreviate from now on as COX, C-O-X. There are subtypes of the COX enzyme, 1, 2, and 3. So just note that. But then this is also important because the inhibition of the COX enzyme is going to block the prostaglandin synthesis. So if we refer back to this, as far as so then what is going on there. Aspirin, like I said, is a little bit different. And other salicylates, it is considered a salicylate. Aspirin is. It's another name for it is acetyl salicylic acid, or that's its, I guess, its proper kind of chemical name. But aspirin is the generic name for the medication. So you can correctly call it either one if you are referring to the generic form of aspirin. And then you can also abbreviate, or you may see it abbreviated, and I sometimes will verbally say ASA. So ASA is the abbreviation for acetyl salicylic acid. And like I mentioned, it's the prototype NSAID, and then it's also, because of that, it is the standard which all the other NSAIDs are measured. So a lot of times you'll hear other NSAIDs, and it's, they'll talk about its strength or its activity, and you just kind of have to know that the reference point is going to be aspirin. So the other thing that's unique about aspirin, and please note this for testing purposes, the only NSAID that is an irreversible inhibitor of COX. The other ones are reversible inhibitors of the COX enzyme. And the other thing that's unique about aspirin and why it's a lot safer, again, relative to the other NSAIDs, we still have adverse effects we need to be concerned with, contraindications, etc. So, but in respect or in comparison to the other NSAIDs, it's the only one that does not have a boxed warning of increased cardiovascular events and increased risk of serious GI bleeds. So we'll note later on, I'll have the specific kind of formal wording for you guys from the FDA, but all the NSAIDs, except for aspirin, have the box warning for increased CV events, increased GI events. So I'm knocking on the table here. I'm kind of getting intense about the, hopefully you guys can't hear me knocking. I feel like a politician here giving a speech, but yeah, so apologies if you hear me banging on the table. I'll try to stop doing that. Just so passionate about aspirin. No, aspirin is really cool. Medication. And I'll try not to get sidetracked on it, but I'm going to, spoiler alert, I'm going to get sidetracked on aspirin. So many of the effects of aspirin are due to its irreversible. So this is mechanism of action of aspirin. Like I said, that's the abbreviation, just FYI. It's not MAO of ASA or whatever, but mechanism of action of aspirin. So yeah, it has an antiplatelet effect and an antithrombotic effect. And this is why you guys remember, hopefully from the cardiology module, where a low dose, aka baby dose, baby aspirin, which is 81 milligrams. So a low dose aspirin is considered to be cardioprotective. It's because of this antiplatelet, antithrombotic effect. Interesting too, kind of historical perspective. There was a few years ago, people were, researchers, not just people on the street, but researchers and scientists were thinking about aspirin in a different way, in the sense that they were like, is this a vitamin? I mean, it's so important, and it has these health benefits. And I mean, is this technically considered a vitamin? Should this be something that everyone's taking? Or, so they were looking at it. And then with that, they found that, that historically humans would actually ingest these salicylates more in their diet, and specifically from wild foods. And I don't know if I told you guys this or not, so you can fast forward this, but the wild foods have the salicylates to protect themselves against things that will eat it or whatever. So historically our diets were full, or had a lot more wild foods in them. So I always encourage students to eat more wild foods if you can, but please be cautious. I'm gonna show you guys a cool website real quick. Okay, yeah, so if you get, and this is just FYI, this isn't on the exam or anything, but if anyone's interested in foraging and eating some wild plants of Texas and the Southwest, this is a great website. It has some great tips and stuff. Edible wild plants, there's ones down in South Texas in the Rio Grande Valley, like purslane, for example, and the prickly pear cactus that you can eat down there. But anyways, yeah, but always be informed and everything, and make sure you know what you're doing, and make sure you have a good reference, and maybe have a local guide or whatever if you're interested in doing that. But anyways, so yeah, that's just something I'm interested in. I just think it's cool to forage for food. My wife and daughter and I like to go out, and we found wild persimmons here in Missouri, which was cool. We found a mulberry tree, which was fun. and then wild blackberries and some other berries that we found that were edible. So that was cool. But anyways, yeah, just this is all FYI. I just want to show you guys this website. I don't think I've showed you this website before. I know a lot of you guys are from Texas, but this is a cool. I think the lady's based out of Houston. But anyways, okay, enough plugging of that. So sorry about that. I just like to show you guys some stuff that I'm interested in, just because you guys are captive audience now. And it's related to, I mean, you might come up with your patients too. There's other people, there's other weirdos like me out there that like to roam the forest looking for food. My wife, by the way, has forbade me. I think that's the proper word. Has forbade me from. I really want to hunt wild mushrooms, and there's a lot of wild mushrooms here that are edible. But there's also a lot of wild mushrooms that can kill you. So she doesn't want. She's seen too many in the hospital that have, and I shouldn't laugh, but that have ingested poisonous mushrooms and stuff. And she's like, "You're not allowed to do." So I out of respect for my wife, I don't pick wild mushrooms. But anyways, the other stuff, I'm like, she didn't say anything about wild berries. No. So anyways. Dose-dependent pharmacokinetics, getting back on track here. Sorry about that side note there. This is relatively important. So, you guys aren't tested on dosaging, and I typically don't make you guys pay attention or stress about the pharmacokinetics, I guess is the better way to say it. This is an instance where I do want you to pay attention to the dose-dependent pharmacokinetics. It is important. So this is an instance where please go ahead and read through this slide, and don't stress too much about it. Again, you don't have to memorize this, but the take-home point I think that's important is that lower doses of aspirin will have the analgesic, which is pain reduction, antipyretic, which is fever reduction and platelet inhibition, and then the higher doses of aspirin have the anti-inflammatory properties. And where that comes into play, it's not so much with aspirin because it's rare to give aspirin at really high doses like that, but it comes into play with some of your other NSAIDs. So these other NSAIDs also have the dose-dependent pharmacokinetics. So for example, with ibuprofen, just note that if you are interested in having anti-inflammatory effects of the ibuprofen, you'll need to prescribe it over 600 milligrams. So your 600, plus milligrams, excuse me, man, didn't catch that cough. And then if you are interested in the analgesic antipyretic properties of the ibuprofen, so just quick note, you won't have the platelet inhibition with ibuprofen, but if you're interested in the analgesic antipyretic properties of ibuprofen, you stick more the 200, 400 range or the lower dose range for ibuprofen. So that is important to note. But like I said, I mean, I'm not going to, that's more for your knowledge as far as when you're prescribing out in practice and everything. Just be mindful of the NSAIDs that, the dose will affect the what outcome you have, and so you do need to be mindful when you're dosing your NSAIDs as far as you're dosing it appropriately. So anyway, so hopefully that's clear. If not, email me. Every once in a while, there's usually a couple students who want me to talk a little bit more about that, but that's the take-home point from this slide. Uses. So this is uses for all of the NSAIDs. No, I'm sorry, that was a verbal error. Cross that. This is the uses for aspirin. And I need to put that up here. You know what? Ta-da! Movie magic. I needed, yeah, because I've had students ask me about it. But anyways, so you notice the aspirin uses lots of different things. It is antipyretic. Just help with mild headaches, mild pain, dysmenorrhea. It can be beneficial with some inflammatory conditions. And then the low dose one can help, like I said, it's cardioprotective, and so can help prevent MI maybe, or some of these some of the issues a person can have with platelet aggregation. And again, this last one here is going to be unique for aspirin, so please, make sure you note that when studying. Adverse effects. So like I said, aspirin still has its issues, its problems. Make sure this is out of the way so you guys can see everything here. But yeah, definitely make sure you study this. Put a star by here. I want you to make sure you guys know about this. Specifically too, definitely going to highlight the bleeding adverse effect, which we've talked about this aspirin and its bleeding effect before in other modules, but that definitely you have to be mindful of that. The gastric irritation is usually mitigated by an enteric coating, which is another way of saying a candy coating. It's not really candy. I mean, it's not like it's delicious, but I remember in pharmacy school they'd always say it was enteric coating was like candy coating, and I was just like, delicious is whatever I would think, but I think like, I don't know, M&Ms or something, or something, yes. But it's basically a protective coating that helps prevent and they call it enteric coating, and it prevents the gastric irritation. So usually enterically coated aspirin doesn't have as much gastric irritation, but it's still there. It's still an issue. And you'll notice here this occurs with some degree with the use of all NSAIDs. So you definitely be thinking about GI adverse effects when you think about the NSAIDs. And then I did a minor edit there, but you guys will get the final polished slides. There are also potential issues with hearing, so please note that. It is luckily reversible with dosage reduction. Also, please note here, the respiratory alkalosis can be a potential issue. So renal failure and then hyperthermia. It seems paradoxical, but please note that as well. And I mean paradoxical in the sense that it can help reduce fever, but then it causes hyperthermia. But anyway, so yeah, please make sure you note all of those. Contraindications, again, put a big star here as usual. The hemophilia, I think, there's some logic behind it because it can increase the risk of bleeding. It has its effect on platelet aggregation, etc. Hypersensitivity reactions definitely can be an issue. This is more common in women versus men, so it is one of those that you may see more in your female patient population. But anyways, and this is also too, I don't know if you remember in the pulmonology module, we talked about an aspirin-induced asthma. So this is part of this hypersensitivity reaction. And it's typically can be treated with the montelukast or the zafralocast. So those are both leukotriene receptor antagonists. So you guys remember that, hopefully from the pulmonary module, but if not, there's a little reminder for you. And then just brand names there, Accolate and Singular. Rise syndrome, again, put a star by that. This is especially for your pediatric patients. So again, for testing purposes for my exam, it's going to be any patient that is less than, 12 years old. I'm slacking on my cough game as far as like pausing it for these coughs. I'm sorry, guys. So definitely please note that. And I say 12 years old is cut off because in the past students have come to me, they found different sources where there are some other guidelines or recommendations that are more strict. I've actually seen students brought me up to where there was a recommendation for no one under the age of 18 to have aspirin or salicylates or aspirin containing products. But for testing purposes, it seems like when I go to UpToDate, it seems like 12 years old is a good cutoff there. But and also for testing purposes, I will not make it tricky. I won't be like, well, he's going to be 12 in 3 months. You know what I mean? Like, or he's 12 years old, 12 and a half years old or something. You know what I mean? I'm going to do like, it's going to be a kid. It's going to be, which that's unscientific kid, but it'll be like a 5-year-old, let's say, or something that's pretty, the person's definitely under 12 years old. Okay. So yeah, I've had students ask me about that too. Like, all right, what if they're like 12 and a half on the exam? And I'm like, so out in practice, I don't just blow students up, but out in practice, clinical judgment, and it's going to depend on the student and your patient and what else is going on with your patient. Right. So I'm always going to say that. And it's also going to depend on how conservative you want to be, like if you want to take the risk or not. If it's a 12 and a half year old and they can take Tylenol or ibuprofen to reduce their fever, and you feel more comfortable with that, that's fine. It's, no one's gonna, I don't think, I hopefully there's no one giving you a hard time about that. Hopefully there's no like abusive physician who's like, why are you, so yeah, I don't think that's that would be, that's just going to ultimately be up to you. But for exam purposes, and I believe the board exams are kind of similar philosophy to mine, or at least the board review questions I've seen, it's very clear that it's a pediatric patient. So don't stress about that. And again, like I said, I get I always appreciate these questions and feedback from you guys and from the last years. I get you guys are stressed out and stuff, so it's no big deal. Sometimes I'm like, hey guys, I'm not gonna put them like they're 12 and a half, but then I'm like, but that's a good idea. No, but I'm not gonna do that. Other non-selective NSAIDs. So again, not all NSAIDs are created equal. So definitely for studying purposes, put them all, aspirin plus all these under the same umbrella of NSAIDs, but then please study the aspirin as being a little bit different. Individual differences. So part of it is going to be potency, duration of action. So here's some examples of those. You don't have to memorize these durations of actions. It's more take home point for studying is that, they're not all exactly the same. And you'll definitely see, especially when you're out in practice, I feel like during your rotations, you'll notice that certain NSAIDs are preferred for certain indications. So And then also, too, certain patient populations. So a young person comes into the ER with, let's say, some sports-related injury or something, you'll notice that they'll be using a certain type of NSAID for them versus an elderly person who comes in with some kind of back pain or something. I don't know. I'm just kind of making these up right now, but you'll notice another one from them. But don't stress too much about that right now for my exam. And I believe, because I believe that's something it'll be a lot easier to learn once you're out on your rotations, and definitely something you see, or at least I felt like that was like that for me in pharmacy school. FDA warning, definitely put a star here. You guys know this already, that NSAIDs have increased risk of cardiovascular risk, and increased risk of GI bleeds, which we will see here. So this is the one for all the NSAIDs. Serious cardiovascular thrombotic events. This is excluding the neoprofen, which is the ibuprofen lysine product, which is an IV version of the ibuprofen. But yeah, just I mean, don't. For studying purposes and for my exam, again, I won't gonna get super tricky and be like, they prescribe neoprofen. What do you do? No, it'll just be, I mean, definitely for studying purposes, I want you guys to have the association with all of the NSAIDs except for aspirin, right? That they have this serious cardiovascular thrombotic events, and then also serious GI bleeding, ulcerations, and perforations. So definitely please read through all that, and please make sure you're noting that when you are studying. Mechanism of action, we talked about that there's some different COX inhibitors, so specifically the other NSAIDs other than aspirin reversibly inhibit COX-1 and COX-2, and this is where they have their antipyretic, analgesic, anti-inflammatory effects. So yeah, definitely read through this. Uses, notice again, a lot of different things here that are similar to aspirin. The one that is a little bit different, and please note when you're studying, is indomethacin. It can be used for the closure of the patent ductus arteriosus. So that will come up again in the OB-GYN module. But please just note that it's a little bit different. Adverse effects. I mean, GI adverse effects are on here. Definitely that shouldn't be a surprise, noting the boxed warning, but definitely make sure you are mindful of and you think of GI adverse effects. And it's something as simple as stomach upset. So a lot of times with these NSAIDs, especially at higher doses, you can recommend that the patient takes it with food, and so taking in these NSAIDs on an empty stomach is an increased risk for GI upset, etc. The other thing too to note with the box warning is it's an increased risk of the box warning with higher doses and longer term therapy. So it's something to be mindful of with your patients, to try to, lowest effective dose with NSAIDs is always wise, and then a shortest duration of action. So you'll hear people say, that when they talk about NSAIDs, and because it's basically because of those box warnings and these adverse effects. Potential for decrease in renal function. So that's something to be mindful of. And again, depending on your patient, older patient, etc. Mention that they can be used for the patent ductus arteriosus. So then it's not recommended in pregnancy after 20 weeks. So that's something to be mindful of. And then there's some electrolyte abnormalities that are potential. So hyperkalemia, hyponatremia, and edema. So again, make sure you study those. And like I said, I like writing these electrolyte disturbances test questions because I see them on the boards. It's not because I actually don't like them. I mean, as far as like when I was a student and writing questions, I always get them. I get them all flipped up and mixed up and stuff. But I see them on the board review, so I'm like, well, I don't want you guys to have a big surprise when you get to that point. So, anyways. Next up, we have the COX-2 inhibitors. So these are more specific. When they first came out, they were the best thing since sliced bread, as people say. And they were amazing in the sense that they had no adverse effects. They were safe. They don't cause any GI adverse effects. They're only hitting COX-2. They're not hitting the COX-1 and COX-2, because you remember up here, the NSAIDs hit COX-1 and COX-2. And that was the reason why they thought that there wasn't going to be the GI adverse effects, etc., because it's more specific. It's only hitting COX-2, and yeah, it was pretty crazy as far as like it went bananas and or gangbusters, as they say. But these were really popular, and then it turned out that they had an increased risk of death with these medications. So it turns out they weren't as safe as they originally thought. So long story short, just for historical perspective, we have a couple of older medications that are no longer on the market, but celecoxib, which is generic for Celebrex, is still on the market. And it's interesting because the reason that the scientists have found that it's relatively safer, and part of the reason it's still on the market, is because it's actually not that specific of a COX-2 inhibitor. So these other two are actually more specific COX-2 inhibitors. So it basically turns out if you only inhibit COX-2 and you're really good at only inhibiting COX-2, it leads to death. And so the Celebrex is actually like a weaker kind of, you can think of it as like kind of a partial COX-2 inhibitor. And that's just kind of FYI, and like I said, historical perspective for you guys. But that's what's happened. I mean, you guys are probably old enough, right? How old are you guys? You're probably old enough to remember that. Were you guys like, I was in diapers in 2005. I love when students tell me that. They're like, last year, like, I was in kindergarten in 2005. I'm like, how old are you? But anyways, so yeah, I don't know how old you guys were in 2005. So maybe you don't remember it, but ask your parents and grandparents and great-grandparents about it. Maybe they remember 2005. But anyway, so yeah, because you may still there. And the reason I mention it is because some of this historic stuff, because there still are going to be patients that were alive in 2005, and they'll remember this, and they may be scared of the celecoxib because of it. So anyway, because it still has its place and it can still be used, whatever. So anyways, more of the FDA warning. Just go ahead and read through that, definitely. And like the other NSAIDs, celecoxib does have the box warnings for, and like I said, initially when it came out, they're like, there's no GI risk, and it's great, and there's like no adverse effects, and it's kind of crazy. I don't know if you guys don't have extra time, but it's interesting to go back and sort of see what the drug companies were saying about these medications when they first came out, because it was interesting. I think I was actually in pharmacy school. I'm gonna age myself a little bit. I was still in pharmacy school in 2005, and that's when all the news was breaking and stuff. So it was like all the pharmacy professors were all super excited. I mean, not excited that people that sounds really bad. Wait, not excited that people were dying, but they were just excited because it was like drugs are in the news and we're going to tell our students about it. Like that kind of excitement. Not so, yeah, man, and this is on record too. Okay, for the record, my pharmacy professors were not excited about people dying. They were excited about just the new developments in pharmacology, I guess I should say. So anyways, I got to watch what I say. All right, mechanisms of action, like I said, they are more selective. And like I said, too, the Celebrex, part of the reason it's still on the market because it's actually a little bit less selective of the COX-2 uses. And so you still see it out there. Primarily, I see it being prescribed, or rather the prescriptions I fill is mainly for arthritis. So OA and RA, rheumatoid and osteoarthritis. Acute pain dysmenorrhea, those are FDA approval, they can be used for that. But not as much, I would think. So, and these typically aren't first line too, because I think practitioners still, because most people prescribing, again, don't want to kill their patients. So most practitioners are still a little bit hesitant or whatever is what I would say. So it's not as popular. So when it first came out, like when I was a pharmacy student in the pharmacy, it was like flying off the shelves. Like everybody was getting this, and we were, when I was a student intern or whatever, there was, we'd fill a ton of prescriptions, and then it's like, then hit the brakes, and then it was like for a couple years, like I never saw it being filled because everyone was scared of it. And then I slowly started seeing it coming back, but mainly specialists prescribe it. Again, this is just my experience in Texas and Oklahoma. So I mean, I don't know, different pharmacists, different pharmacies, but as far as what I've filled, I've mainly seen it more for specialists. So it'll be interesting to see what you guys see it, out there on rotations. And because the last pharmacy I practiced in the Valley was Fry's Pharmacy. Shout out to Fry's Pharmacy in San Benito. Shout out San Benito, Texas. And then I worked at the same time I was working at Texas Tropical in Edinburgh and in Harlingen. Yeah, so shout out Texas Tropical, Edinburgh and Harlingen. Sorry, I just got to shout these people out. Adverse effects, like I said, they initially thought that they didn't have GI bleeding, but still GI bleeding, renal failure, and then the cardiovascular events. So definitely make sure you're studying those. Changing gears here a little bit, we're going to acetaminophen. Paracetamol, aka paracetamol is another name, aka N-acetyl P-aminophenol, which I've actually never heard anyone say that, but maybe there's going to be some patients out there that are like, oh yeah, I was wondering if you could increase my dose of N-acetyl P-aminophenol. But yeah, so that's where you get the abbreviation. You may see APAP APAP. That's where it comes from. So acetaminophen, aka paracetamol, aka APAP. So those are three names. You can use them interchangeably if you want. Honestly, though, the paracetamol is something that I feel like is used more overseas. I always, anytime I say it in my head, I have like a British accent, which I don't know where that comes from. But I just have this, and then also too, like my wife's family's from Nepal, I've mentioned. But so Nepal and maybe India, they say paracetamol. I've noticed over there. And maybe that's from the British too. I don't know. I don't know why, but I just mainly hear people refer to it as acetaminophen, which is the generic, or they just say Tylenol because Tylenol is a brand name. Again, it's like one of those Coca-Cola, it's like Coca-Cola. Like a lot of people just call it Tylenol, but you will see the APAP, and definitely you'll see the APAP when it's in combination. So it'll be oxycodone, let's say, with APAP. And you can write your prescriptions like that as well. You can write this for Tylenol if you want on the prescription pad or electronically or whatever. So anyway, so that's just the background on that. For testing purposes, I'll be clear cut. I'll use acetaminophen. I won't put N-acetyl P-aminophenol. It's kind of fun to say. But anyways, I won't. If I should go around, sorry. No, I don't want to be that guy. I don't want to be the annoying guy in the pharmacy. Just go troll the pharmacist at my local Walgreens. Be like, hey, where's your N-acetyl P-aminophenol? Captain, they'll probably like right there, aisle 3. Boom. I'm a Walgreens pharmacist. I don't got time to mess around with you. So anyways, these are classified as non-opioid, so they're not opioids, and non-NSAID, because they're not NSAIDs, analgesics. And so please note that. Had students in the past and on my exams and stuff get Tylenol. I think because it's like the next slide, and so I've had a couple students that I felt really bad. They missed exam questions because they were classifying acetaminophen as an NSAID. So please make sure you're keeping it separate. Also on that note too, it has no anti-inflammatory activity. So definitely highlight that. Again, students in the past, and I think really in reflection, it's just because it's like in the same slides, and it's just you guys are busy and there's a ton of drugs, and you just kind of So anyway, but please note it has no anti-inflammatory activity. It is good at pain reduction, so analgesia or analgesic, and then antipyretic, so it's good for pain and for fever. Mechanism of action, this is one of those that is not fully elucidated, which I remember in pharmacy school, I was like, this is a ripoff. Like I came to pharmacy school to learn about Tylenol. Like, what is Tylenol? Because it's like, I feel like that was like the only drug I knew before going to pharmacy school. Like I knew like Tylenol and maybe Motrin. I don't know. Like, because luckily my family isn't super sick or anything. We didn't really take medications growing up. So, but like we had Tylenol and like a cough syrup, like Robitussin. Like I knew those two things. So I remember being like, what do you mean you don't know? Like, how long has Tylenol been around? But yeah, so just for mechanism of action, it's technically, again, you go to UpToDate or with Lexicomp or whatever, it's not fully elucidated, which in other words means it's unknown. They think that it has these effects. So you can go ahead and read through this, and this is kind of the best scientific guess right now. So there's no harm in studying it, but yeah, it's one of those that, and so hopefully you guys don't feel ripped off like I did. I was like, what am I paying for? I'm paying for, you guys need to figure out why. No, but anyways. So like I said, it's good at pain reduction and at breaking a fever. So it's a big player in fever reduction. Can be used too for osteoarthritis. So it's just going to kind of, again, depend on your patient, but it's ubiquitous in the sense that Tylenol is out there. It's, inpatient, outpatient, urgent care, ER. I mean, it's surgeries. It's like with a lot of these medications, you're going to be seeing it all over the place. Okay, so this has got a lot of stuff going on, but it's really important stuff here, as usual. With the adverse effects, you definitely need to be thinking about the liver. Tylenol is a liver killer, and not like in a cool way, like, okay, never mind. This is reference to something that another student said to me, but not going to go down there. But yeah, definitely hepatic necrosis, liver killer, hepatotoxic medication is definitely something you need to put a star by and think about with Tylenol. Related to that, chronic alcohol consumption can potentiate, which means make worse the liver toxicity of acetaminophen. So definitely something you need to be mindful of with your patients who consume alcohol, and especially those who consume a lot of alcohol, and then have chronically consumed alcohol. So that's something to think about. And this is why in pharmacy school, they're like, maybe Tylenol is not a great idea for your hangover. So, I mean, I definitely don't encourage people to drink alcohol if they're under 21. I don't, because I don't know how old you guys are. Probably all you guys are over 21, but I always encourage everyone to drink responsibly and not overdrink. But if you do overdrink, you have a hangover, stay away from the Tylenol. It's probably not a good idea. And, you know, go with some other remedies or whatever. But also, please note that the mucimist, the N-acetylcysteine, please put a star by that. That is used to prevent hepatotoxicity with a Tylenol overdose. It's also interesting and worth noting that you do not have to worry about the gastric irritation, nor the platelet function effects with acetaminophen or with the Tylenol. So that's where it's a little bit different than the NSAIDs, and it may be a reason why you prescribe it. If a patient is having issues with the gastric or the GI adverse effects with the NSAID, that may be a rationale to then switch them to the Tylenol, acetaminophen. There's still a box warning, specifically with the injectable form of acetaminophen, but I put that here just because I like to make sure you guys know about the box warnings. And it probably won't be a surprise to you, note that it is involving hepatotoxicity. Hepatotoxicity, I don't know why I said it with the weird accent, hepatotoxicity there. It is a big concern here in the US. There is I don't know if anyone listens to This American Life podcast, but I like listening to it with Ira Glass. I won't do my impersonations. But they had, and this was a year or two ago, couple years. But anyways, they had an hour-long podcast dedicated to Tylenol toxicity or acetaminophen toxicity in the US, because unfortunately it is one of the most commonly reported products that causes drug-induced liver injury, which is abbreviated DILI, which I think is kind of funny, but it's a very serious thing, DILI, in the US. And it's also the most common of acute liver failure, which is ALF, in the US, which is also kind of funny abbreviation. But anyway, so that maybe help you guys when you're studying. But it's definitely something that you need to be mindful of, and that's definitely something that you'll see, you know, some hospitalized patients for, et cetera. And with these overdoses, it's intentional and unintentional overdoses. So that's something to note. The other thing too is that there was some controversy. There was some maybe public reaction to sort of this, you know, the toxicity, and there was some push, and some scientists and some experts considered lowering the max dose of Tylenol. But it's 4 grams every 24 hours. You may see some things that recommend not exceeding 3 grams or 3,000 milligrams every 24 hours. So, and again, it's just going to kind of depend on your patient. Do they, you know, drink alcohol chronically or not? Maybe you don't want those patients going over 3 grams. And yeah, so but yeah, 4 grams, 4,000 milligrams. And again, that won't be on the test. I'm not going to make you guys memorize that, but definitely when you're out in practice, when you are on your rotations, etc., please keep that number in mind, 4,000 milligrams. And the reason I mention that, in a reason a lot of people have accidental overdoses, is because a lot of products, well, you notice here it's the most widely used analgesic antipyretic in the US, but a lot of products have Tylenol in them. So I mentioned the cough syrup growing up. So a lot of cough syrups over the counter have Tylenol in them. A lot of the flu and allergy, or, you know, cold and allergy, cold and flu. If again, I know you guys don't have a lot of extra time, but next time you find yourself in the drug aisle at HEB or the local pharmacy or wherever, start flipping the boxes around and checking out, and you'll notice that a lot of them have acetaminophen in them. And so where people get into trouble is, it's not, you know, I mean, you guys are healthcare, are going to be healthcare practitioners. You're educated in, you know, in pharmacology, obviously. And so it's not that big of an issue for you, maybe, when you're taking medications, because you can be mindful of your Tylenol. But definitely you know, with the lay public and with over-the-counter products, and then with parents who have small children, they get in trouble and they accidentally overdose their children, or accidentally overdose themselves with acetaminophen, because it's like, well, I'm taking a cough syrup, and they don't think that has Tylenol, and I'm taking this my allergy medication, which the allergy medication happens to have Tylenol in it, and then there's this prescription you gave me that has Tylenol. Like, let's say it's a pain medication that has a combination thing with Tylenol, or it's a headache medication that has something with Tylenol in it, and so right there, they're taking 3 things with Tylenol, where they maybe only know that one of the three has Tylenol in it, because it's like, well, an allergy medication, cough syrup, those don't have, and it's like, well, they're correct in the sense that there are some cough syrups that don't have Tylenol, but again, they need to be mindful of it, and it's part of the reason why there's so many issues with the toxicity. And it's definitely something, I mean, even as healthcare providers, definitely when you're doing your chart reviews inpatient setting, or your chart reviews outpatient setting, look at, you'll be surprised. I'm guessing you'd be surprised, because I was surprised as a pharmacist when I came out of pharmacy school, because I was taught this in pharmacy school, and I'm like, well, yeah, I get the lay public, but I'm like, healthcare providers, there's no way. Like doctors and PAs and everybody, they know what they're doing. But you'd be surprised at how many times that, and it's unintentional. I mean, it's not like the PAs are trying to hurt people or anything, but it's like they don't know that they're getting, they don't know they're taking some over-the-counter medication that I know that they're taking in the pharmacy, and then, or maybe they have a couple prescriptions from a couple different providers, or the big thing that would happen, or the thing I would see is, this is when I worked for the as a consultant in the nursing homes for a year, that there would be, PAs, physicians would have assumed that things were discontinued and they weren't. So there'd be, the person would be on 4 different things that had Tylenol in it, and I'd call the provider, and they're like, oh yeah, but they're only on, this one thing that I prescribed them. And it's like, well, these other things weren't discontinued. So the nurses are they keep giving them, and, there's an overdose of Tylenol potential here, because, there's all these as needed medications or scheduled medications that, the patient's getting. So anyways, I don't want to spend too much time. I could talk about Tylenol toxicity for like an hour. And like I said, there's that This American Life podcast on it that was great, and sad too. I mean, because there's some kids that died and stuff because of Tylenol overdose. But yeah, just please be mindful of your Tylenol dosing. I'll just end there with that. Switching gears here a little bit, we're going to talk about migraine headaches. So just for some background and everything, I included some of these slides because I'm not sure exactly what all they're going to be going over in Pathophys and in ICM with you guys. But this is just some definitions and some background, just so everyone's on the same page. You don't have to worry necessarily about memorizing this or this won't be. This is an FYI slide, and then this will be an FYI slide for testing purposes for my exam. Excuse me. And this one as well. This is just showing that there's just different phases, starting with the prodrome and ending with the postdrome. Again, just FYI. All right, here's definitely stuff I want you guys to know about. First class we have is a big player here. These are called the triptans, quote unquote, and that is because they all end in the same ending of triptan, which is nice, I think, when you're studying and when you're learning these new drugs. And these are all the generics here. I did something a little bit different here. These should be hyperlinked to LexiComp, which is on UpToDate. Yeah, UpToDate.com. But anyways, there was something I was playing around with last year and I kind of experimenting with. I ended up not doing it, obviously, for all my slides, but it was in these slides and I just left it. But anyways, yeah, let me know if you guys like the hyperlinks or not, actually. Because last year, I got kind of a mixed reaction. I was like, eh. But anyways. So sumatriptan is the prototypical one. So this is the prototype drug, the first one, the oldest one out there. So a lot of times too, like with some of these other like medications that are the first ones, like sildenafil, for example, in the GU module was the first PDE5 inhibitor. You'll notice that a lot of things will be compared to the sumatriptan and or reference to it, or like when they talk about adverse effects, they'll be like, well, these are the adverse effects we saw with sumatriptan, so we kind of assume that they're with the whole class, or like, oh, this is an improvement of sumatriptan, or anyway. So that's just note that was the oldest. Mechanism of action, it's the same for all of them, so please put a star there. I want you guys to make sure you're studying mechanism of action, and specifically it's a serotonin, but these specific subtypes please study. So 5-HT1B and 5-HT1D, as in dog. Make sure you know it's a serotonin agonist, which is good to study, but then specifically 1B and 1D. Definitely go ahead and read through the rest of the mechanism of action when you're studying. Adverse effects here, the top 2 are CNS adverse effects. So this is something to be mindful of, and this is part of the reason I'll have a warning, like do not operate heavy machinery and stuff. But so it's CNS depression, dizziness, or maybe some common adverse effects. Excuse me. Paresthesia, which is the pins and needle feeling, can happen. There can be some cardiovascular concerns too, so please note that. And then the Raynaud's phenomenon, rare but serious. adverse effect. Contraindications, please make sure you study these and make sure you know. There is a potential drug interaction with the ergotamine derivatives, which we'll talk about in a little bit. And so make sure you note that. Please note too that there are the pregnancy implications there, and so it won't be your first line medication for your pregnant patients. And severe tobacco and tobacco smoking, again, all important stuff here. Just note too that they do make a combination of sumatriptan plus naproxen. They call it Treximet, and this is will help treat moderate to severe migraine attacks. So this is a combination NSAID plus the triptan, which we'll see that those are both potential players. And so this may, again, if you feel like a patient needs to be on NSAID plus a triptan, this may be maybe an option for your patients, but the cost may be an issue too, and insurance may not cover it, etc. So just be mindful of that. Next up, we have the ergot alkaloids, which please note up here, we talked about that there is a drug interaction with the triptan, so please note that. These are older medications. Before the triptans came out, they were maybe used more. They're not really used as much as they were. So historically, you maybe saw these in other countries too. You may see these still being used or prescribed, but really the triptans now have taken over as far as they're a lot better tolerated. These had pretty bad adverse effects. And so anyways, yeah, so that's where you don't see these as much. Mechanism of action, you notice it does similar to the triptans. And yeah, and this is showing that they're not really exactly sure why it's beneficial. The significant side effects, and then some things that may actually worsen the migraine, or the nausea and vomiting associated with migraines is part of the reason that they aren't really, they fall out of favor. There's also problems with them causing headaches, and then too, long-term use can cause valvular heart disease. And like I mentioned, this worsening the nausea and vomiting associated with migraine, which I have on that twice. So I don't know why I have that there twice. Okay, yeah, I took that out. I was like, I don't know why I have that may worsen nausea and vomiting associated with migraines twice. But also, there are boxed warnings with these medications, so they you have to be concerned and mindful of drug interactions. That's another reason why these aren't popular. So please read through that, but that is related to a box warning with these medications. And then contraindications, you'll notice more reasons why they aren't popular, and you'll notice they actually are worse for pregnant women, relatively speaking, to triptans, but triptans still, again, aren't first line for pregnant women, but just notice too that they have a lot of contraindications too you have to be mindful of. So I went through this. This is kind of a little pharmacotherapy for you guys. Again, I'm not sure exactly how much detail they're going to go in ICM. So what happened last year was that the person doing ICM didn't talk about any of this stuff, and so the students asked me to do this quick little breakdown for them. So this is why this isn't here. So it's still good stuff, but and so my apologies if it's going to be repeated in ICM. But anyways, so for the acute attack, you have some different things you can go with. NSAIDs we talked about, and there's some lists of those you can use. Triptans we also talked about, and there's a list of those. There's a combination product, NSAID plus the triptan, and then you can also use antiemetic or the dopamine receptor antagonist, and those will help, especially if a person has nausea associated with their migraines, nausea, vomiting. Analgesics here, you'll notice you can kind of pull from some different classes. We haven't talked about the opioids yet, but a couple opioids that may be beneficial. You notice Tylenol made the list there, and then we have some other NSAIDs that can be used. So there is not, so you, with a person who has migraines, you want to obviously decrease the number of attacks they have, and you want the person to have a better quality of life, right? Unfortunately, the experts have not agreed or cannot agree on a one-size-fits-all for prophylaxis. So there are some different classes that you will be seen employed for migraine prophylaxis. Beta blockers, calcium channel blockers, antidepressants, and anticonvulsants. So, and it's also going to kind of, where you start and where you go, and I have some examples here, is where it's going to depend on the patient. So, you know, does the person have issues with blood pressure or not? You know, antidepressants, or do they have problems with depression and migraines? That may be part of it. But then honestly too, I've seen where people who don't have any problems with hypertension, they're put on a beta blocker for migraine prophylaxis. Same thing, I've had patients that are upset that they're prescribed an antidepressant because they have headaches, and it turns out, they don't have any depression, but then they're given venlafaxine, and then the package insert says that this is an antidepressant medication. So same thing here. If a person has seizures and migraines, might be a reason to go with the anticonvulsant, but these are also mood stabilizer drugs, and they can be effective in preventing migraines. And the same thing with the calcium channel blockers. I've seen it both with people who have high blood pressure and people who don't. So really with this, this is going to be more the art of medicine. And again, look at your patient, kind of determine if they have a rationale for one over the other. And then adverse effects and what other medications they're on, and et cetera, et cetera. So really, when you're picking the prophylactic migraine medication, you really need to look at the full clinical picture, and just, like I said, it's more of kind of the art. Again, for testing purposes, I will make it clear cut if I have a question over these medications, as far as what I'm asking and stuff. I'm not going to make it super nuanced and really complicated. My point is, I want you guys to make sure you're studying these medications and you know that this is a list. These are the classes for prophylaxis, and then these are the specific ones of the class. So these are specific beta blockers that can be used as prophylactic treatment. So hopefully that helps studying, and hopefully helps kind of reduce your anxiety about my exam and stuff. One other thing that's interesting to note: my wife's on a rotation this month with an ophthalmologist, and she was telling me that the timolol, that they'll use that as an eye drop for an eye drop formulation to help with migraine prophylaxis. So, and she'd asked me about it. I was like, I never heard that. So I'm passing that on to you guys. That may be something you only see with specialists. Like I said, I haven't come across it before. I don't. Maybe it's super common. I don't know. Who knows? Learning new stuff every day, right? So, yeah. So for testing purposes, just please know that these are all the classes that can be used for migraine prophylaxis, and then specifically which ones of those classes I have listed here that can be used to help prevent migraine headaches. So that is it for today, or for this presentation rather. So hopefully it was good. You guys learned some stuff. But as always, feel free to email me if you have any specific questions, comments, feedbacks, or whatever. Thank you guys for your time and attention. I'll talk to you later.